Good morning, everyone. Sorry for the delay. It had been a few technical issues. Welcome you all to the lecture on anaphylaxis. This is actually in collaboration with College of Anesthesiologists and Intensivists of Sri Lanka that we are conducting this as island-wide lecture series focusing on raising the awareness on management of anaphylaxis preceded by recent few incidences that has occurred in the country. So this is declared as Acute Care Response Week from 24th to 28th. It is very shortly, with short notice, our clinical society and our administration managed to arrange this lecture on behalf of our college, and thank you very much for that. Without much uh, delay, I will move on with the lecture. Yeah. Anaphylaxis. So, what is anaphylaxis? I think you all are aware about this definition from your medical school days. So, anaphylaxis is a serious systemic hypersensitivity reaction. So, it is basically hypersensitivity reaction which is systemic. And what is so special about anaphylaxis is it's rapid and it can be fatal. So, identifying early identification, prompt management will prevent a mortality. So that's why we are so concerned about management of proper, appropriate, timely management of anaphylaxis as medical healthcare providers. All of you should know how to manage anaphylaxis without letting it go into a mortality. So it is potentially life-threatening. What is potentially life-threatening? It's basically airway, breathing, and circulation will be affected. And mind you, without typical skin rash, there can be anaphylaxis. So only 80% of the time you will see the typical skin rash. Without that, you can have anaphylaxis, and also without circulatory shock. So basically, airway and breathing involvement, basically laryngospasm, bronchospasm. Only that those two features can be there in a setting of anaphylaxis. So remember that. Who gets anaphylaxis? So children, young adults, common in females. I don't know what's the reason. And the worldwide incidence is increasing because there are new allergens in the environment. So basically, very briefly on pathophysiology, uh, basically with an allergen it sensitizes your immune system. So with the second exposure it will cause a widespread mast cell activation, so release of all the immune mediated cytokines, inflammatory mediators. So it will trigger a systemic response with regard to cardiovascular, respiratory, and all the other systems will be affected. So types of anaphylaxis, there had been a slight change of nomenclature. So previously we used to say anaphylaxis and anaphylactoid reaction. So basically the anaphylaxis now it had been changed over to immunologic mechanisms. I mean IgE dependent, and there can be IgE independent anaphylaxis as well. And there can be non-immunogenic mechanism where direct mast cell activation can occur. Leading causes. What are the commonest antibiotics that you encounter having anaphylaxis? From the audience, what is the commonest antibiotic? It's beta lactams, yes. Beta lactams and muscle relaxants, anesthetic agents are also in top of the list. NSAIDs, um, so those are basically drugs. So you can have anaphylaxis for food, insect stings, and also latex. So those are few common triggers. Again, how to diagnose anaphylaxis? So to diagnose anaphylaxis, you can have skin and mucosal involvement and at least following three criteria. One of the following three criteria that would be respiratory system compromise, where you will have dyspnea, wheezing. It can be stridor or a bronchospasm, or your cardiovascular collapse, or there can be gastrointestinal involvement. So three systems. One of these three systems can be affected with along with skin and mucosal changes. Or so that is one way of diagnosing anaphylaxis. Or there can be acute onset hypotension, or a bronchospasm, or a laryngospasm. One of them. In that setting, you may not be having skin changes. I think you have got it. So you can have with skin changes, you can have hypertension. Then it's anaphylaxis. With skin and mucosal involvement, you can have laryngospasm, bronchospasm. Again, it's anaphylaxis. With skin and mucosal involvement, you can have gastrointestinal features. Again, it's anaphylaxis. Or else you can have hypotension only with the possible trigger. Then again, it's anaphylaxis. Or you can have laryngospasm, bronchospasm. There's no other feature. But if clinically highly suspicious, you have to treat it. So again, recognition of anaphylaxis, always adhere to ABCDE approach. Any deteriorating patient, I think we have been stressing over this since our ALS program. So ABCD approach is the must because we are addressing the killers. So from airway, breathing, circulation, disability, exposure, you are addressing the killers. So what are the airway problems you can have? What are the airway signs? Now you are going to diagnose, figure out whether this patient is having anaphylaxis or not. What are the airway things that you want to look for? Can they have stridor? Yes, they can have. They can have hoarse voice, and they can have difficulty in breathing. Sometimes they will tell, "I can't breathe," and they can have airway swelling. So there can be lip swelling, there can be pharyngeal swelling, laryngeal swelling, and breathing problems. Breathing, patient can be tachypneic, patient can have shortness of breath, increased work of breathing, that is, patient is using the accessory muscles, and also due to hypoxia. Now, with all these problems, patient can become hypoxic. With that hypoxia, patient can be confused as well, and ultimately, patient can have respiratory arrest. Circulatory problems. What are the circulatory problems that you can see in anaphylaxis? In the setting of anaphylaxis, you can have pale, clammy peripheries and tachycardic hypotension. Again, you can have reduction in the conscious level as well. And ultimately, what will happen? You can have cardiac arrest due to anaphylaxis. Disability. Patient can be anxious. Patient can be panic. This is contributed by both the hypoxia and hypotension because the cerebral perfusion get affected. So skin and mucosal changes, basically you will have these urticarial rashes, but mind you, it is seen only in 80% of the cases. So you will have anaphylaxis without skin presentation as well. Erythema urticaria, angioedema. How do you identify angioedema? From the audience, I think they are falling asleep. It's too early, I think. Yeah, what are the features of angioedema that you can figure out? Swelling in lips, eyelids. Yes. Management, the most important part, so don't sleep. So there are basically two algorithms. Algorithm 1 and 2, basically management of anaphylaxis, initial management, and the refractory anaphylaxis. I'm not sure whether you can see it clearly. Better. Is it better? Yeah. So, as I said, you have to attend the airway breathing if there's any problem. So you have to, you have to stabilize the airway with regard to airway and breathing. So that's why we have, like I have elaborated on the symptoms and signs you can find in a patient with anaphylaxis. So you have diagnosed, now you have diagnosed anaphylaxis. So there can be sudden onset airway breathing issues, or hypertension, circulatory collapse, or unusual skin changes. What will you do first? First thing, any emergency, what is the first thing? Can you manage it alone? Yeah, you have to call for help. So, slightest doubt about anaphylaxis, call for help. Call for resusc team. Unfortunately, still we don't have established resusc team in our hospital. I think in future we will be able to fix one. So remove the trigger. If you have a slightest suspicion of anaphylaxis and there's a possible drug or a blood product or any cause of trigger that you think it can be the cause, please make sure you remove that trigger. And if it's a drug, don't use that cannula again. Remove it off, or else you have to let others know, don't use that cannula, put another cannula. So you will be flushing the your allergen again. So removing the allergen is the first thing. And what you will do after that? You have to flatten the patient. What's the purpose of flattening the patient? Now this is going to be a distributory kind of shock, because will have a vasodilation, widespread vasodilation that will cause you hypotension. So your aim is you will make it as a fluid bolus as soon as possible. You get your blood which is pulled into the legs towards your heart. So simplest thing, you make the patient lie flat and you elevate your leg in. So sometimes some patients, especially if they have respiratory involvement like bronchospasm, they have breathing difficulty, they will find it easy to sit up. So let it be. Then, having done the basic measurements, so you make sure that your trigger is removed, you make sure there's IV cannula, you make the patient flat, you elevate the leg again and get a fluid bolus in. What is the definitive treatment for anaphylaxis? Slight suspicion, it doesn't matter, you will cause a death or you will not do a harm for the patient. So with the slightest doubt, what is the drug of choice for anaphylaxis? It's adrenaline. What is the prefix? It's IM adrenaline. It's always IM adrenaline, unless it's perioperative anesthetic setting. Even the patient is having a cannula, it is recommendation. It's recommended IM adrenaline. What is the adult dose? 0.5 ml from your 1 in 1000 vial. The vial comes, it's 1 in 1000 and it contains 1 milligram. So you can give 0.5 ml to your, what's the site? What's the site? Yes. Anyone have given adrenaline? How many of you have given IM adrenaline? No one? What was the site? It's anterolateral thigh. I think surgeons will know about the anatomy. I don't know. It is a safe site, isn't it? It's a safe site. Safest site is the anterolateral thigh in the middle third. It's anterolateral thigh. So you give 0.5 ml adrenaline. So then after the definitive treatment, you have to again reassess the patient. You go for airway breathing circulation disability, exposure, and reassess. So you assess for the response. What are the expected responses now? You expect the patient to get better with regard to cardiovascular stability, respiratory system, and general condition. If with first dose of adrenaline, even with that, if the patient is still having hypertension at 5 minutes, what will you do? Or the patient general condition, it doesn't improve. Patient is still tachypneic, still there's a stridor, still tachycardia is there, capillary refilling is more than 2 seconds, and patient is complaining impending doom. What will you do? Can you repeat IM adrenaline? Yes, you can. What is the dose again? Yes, Dulvi. Point 0.5 again IM. Now you have given second dose. So you can give up to two doses. After that, what will happen? You will again reassess. Let's say with the second dose, patient get improved. So what are the other measures that you can do? You can give a fluid bolus, about 500 to 1000 ml. You can give even up to 2 to 3 liters. You can give in adults. Pediatrics, of course, you can give about 10 ml per kg. What is the pediatric dose? What is the pediatric adrenaline dose? From 12 above it's same dose, adult dose. 6 to 12 years it's zero point 0.3 ml. Then 1 year to 6 years, what's the dose? 6 to 12 years it's zero point 0.3. Less than that it's 0.15. That's the pediatric dose. So you can give 10 ml per kg bolus for peds. So that's it about initial management of anaphylaxis. Is it clear? Any doubts you want to clear? So, basically, what we have discussed, do not delay the definitive treatment. If not, I mean, remove if your trigger, if it's not feasible to remove the trigger even, do not delay the treatment. You have to give IM adrenaline. So this is basically the positions that I have been discussed. So you can lie the patient flat, elevate the legs, or some patients they prefer sitting up, seated up position. And if pregnant mothers, you can adhere to left lateral position to prevent the aorta caval compression. First line treatment adrenaline, side disease we have discussed. So 6 to 12 years, 300 mics which comes into zero point 0.3 ml of 1 in 1000 adrenaline. 6 to 6 years, 6 months to 6 years, it's 1.5. Less than 6 months, it's 0.1 to 0.5 ml. So basically actions, just a brief go through. So it is basically alpha receptor agonist action which causes peripheral, reverses the peripheral vasodilatation, and there's a beta agonist action as well which will dilate your bronchioles, bronchial dilatation, and it will actually inhibit the mast cell activation. Mast cell stabilization action is there. That's why the further release of your histamines, inflammatory mediators will be inhibited. So you have to establish the area if there's any. I'm not going into detail. I think you all can figure out what I'm talking about. If there's a airway issue, you have to address that. So you establish your airway, you give your definitive treatment, then you have to establish your airway as well. So there's a place for high flow oxygen. If you have high flows in your ward setup, you can use that. What we have is, I think, non-rebreathing mask with your reservoir bag. You can provide 100% oxygen through that. So you can use that as well and establish the monitoring. So basic monitoring, pulse oximeter, ECG, blood pressures. And what is the target saturation? What's the target saturation if you want to achieve? It's 94 98. Basically, about 94 is enough. If unless it's a COPD patient, which is lower targets are adhered around 88 to 92. So this is what I have already discussed. You can give crystalloid. Don't forget crystalloids. That's the thing. So you give adrenaline, but same time you have to fill up your intravascular compartment as well to overcome the distributary shock. So give good volume of fluid, about 500 to 1000 ml. You can give up to 3 to 5 liters in adult, very large volumes. They can accommodate very large volumes. So you can give crystalloids. What are the crystalloids you can give? Normal saline or ringless lactate, yes. So that's about the basic anaphylaxis algorithm. So what is refractory anaphylaxis? What's the definition of refractory anaphylaxis? If yeah, if there's no improvement in your symptoms, cardiovascular respiratory systems, despite two appropriate doses of IM adrenaline, that is you give one, after fifth minute you give second one, there's no improvement, then you go into refractory anaphylaxis algorithm. So basically what happens in refractory anaphylaxis, you have to start IV adrenaline infusion. How would you prepare IV adrenaline infusion? Now you don't have central line with the patient who just got anaphylaxis at your ward. So how would you give adrenaline for this patient? Infusion. Peripheral. You take about 100 ml to a burette set and you put one vial. So from that you can titrate zero point 0.5 to 1 ml per kg per hour. That's how you give adrenaline IV via peripheral access in refractory anaphylaxis. If you find it, if there's a delay in establishing IV adrenaline infusion due to some reason, what can you do? Now you have to establish IV adrenaline infusion, but still not happening. What can you do? It will not happen anyway in the ward, isn't it? As soon as you tell, it will not happen within next 5 minutes. So until such time that you establish the IV adrenaline infusion, you have to repeat your IM adrenaline every 5 minutes. Simple as that. So meanwhile, you have to make sure that your ARV is attended, your IV cannulation is attended, and what's the place of hydrocortisone and chlorpheniramine? I think it's a burning question. Is there a place for IV and hydrocortisone and chlorpheniramine? Yes, in refractory anaphylaxis, not in acute setting. Don't delay whatever your definitive management, like trying to give hydrocortisone in acute anaphylaxis. It's for refractory. Now, this context you can give hydrocortisone because it will delay the secondary, biphasic response. Is that clear? It's about refractory anaphylaxis. Any questions up to now? No questions. Fast asleep. Yeah. What about IV adrenaline? I have briefly touched on that. If the patient is under anesthesia, you can give IV adrenaline. So, how many anesthetists? Gynae is there. Yeah, she knows how to give adrenaline. Others interested, if interested, I can tell. So you can give 1 in 10,000 IV adrenaline aliquots. Aliquots about zero point 0.5 to 1. That is under anesthesia. All the other settings, you are not advised to give IV adrenaline because it should be handled by experts. So this I have already discussed. Peripheral IV infusion, that should kept in mind how to make the peripheral IV infusion. So monitoring. So how would you assess for the adrenaline response? The tachycardia should be, adrenaline overdose. This monitoring, basically the monitoring you put on to assess the, response and also overdose of adrenaline. Now you have started IV adrenaline infusion. If there's unnecessary tachycardia or arrhythmia or hypertension, you can come down on the dose. Infusion, I tell you, because there will be definitely there will be arrhythmias, there will be tachycardia, hypertension with the adrenaline infusion. This I have discussed. So steroid antihistamines, remember there's a place only in refractory anaphylaxis. Not in acute setting, definitely not in acute setting. Don't be hurried to give hydrocortisone, chlorpheniramine. It's IM adrenaline that you have to give. So even antihistamines, recommendation is you can give oral. If the patient is stable enough, you can go for non-sedative antihistamines like cetirizine oral, about 10 milligram. If the oral route is not possible, then you can give IV agent. This is hydrocortisone. Hydrocortisone you give about 200, and there's pediatric doses as well. Glucagon will play a role if the patient is on beta blockers. So this is what I have been talking. Biphasic reactions can occur. So anaphylaxis can appear to resolve, but it can recur with the symptoms even without further allergen exposure. That is biphasic reaction. So what about these tryptases? So if you are not very sure of the diagnosis only, you can send this tryptases. If the clinical scenario is very obvious and the background is very obvious, no need to actually send tryptases. But if there's a diagnostic dilemma, you can of course send the tryptases and see. So when would you send the tryptases? You can send the sample as soon as possible if you diagnose anaphylaxis, but don't delay your management just to take these blood samples. So after stabilizing the patient, if you diagnose anaphylaxis, take one sample as soon as possible, second sample within 2 hours, third sample within 24 hours. What if a patient go into cardiac arrest with the possible anaphylaxis? Then what's the route of adrenaline? It is if the patient, whatever the cause, if the patient is in cardiac arrest, you should stick into your ALS algorithm. That is, you give IV adrenaline if the rhythm is non-shockable. So basic ALS algorithm should be followed even if the cardiac arrest is due to anaphylaxis. Simple as that, because no point in giving IM adrenaline in the arrest patient. So this is the chain of survival, as you can see: early recognition and call for help, early CPR, early defib, and post resusc care. This is, we have been talking this for last couple of weeks now, I think. Yes. So cardiorespiratory arrest during anaphylaxis, you start your CPR. It should be high quality CPR, same 100 to 120 compressions per minute, 5 to 6 centimeter in depth, in middle, lower half of your mid of the chest, lower half of the sternum, and 30 to 2, 30 compressions, 2 ambu breaths. And early rhythm check should be done. Shockable and non-shockable pathways should be adhered to. If it's asystolia or pulseless electrical activity, you would give IV adrenaline 1 in 10,000 1 milligram. If it's shockable, you go for shocks, defibrillation. That's it about anaphylaxis. And anaphylaxis during pregnancy, there's no difference except for positioning. So you would position the patient in left lateral position to prevent the aortocaval compression. So if you have a patient now, you have a suspicion that this patient got anaphylaxis. So basically, if the patient had a good response, you can actually observe for about 6 hours, and that's it. But if there's a refractory anaphylaxis or the patient is having recurring symptoms and ongoing needs, of course, you then need a critical care admission for this patient. So there are diagnosis cards or medical alert bracelets. So you can issue them on discharge to the patient. Please give a card written in red that this patient had an anaphylaxis. So how would you minimize the severity of potential reactions? So this is, you can always ask from the history whether the patient has allergies, medical records, and what about the drug preparation? So severity of potential reaction you can reduce by diluting the, if you are giving IV antibiotics, the diluted form will cause reduced severity. So you have to give the standard dose, correct dilution volume should be adhered to. If you administer it slowly and over about 10 to 30 minutes, and use an infusion preferably. Now, this for this Traxone issue also, they have advised to dilute it and give like about 30 minutes. I'm not sure whether it's feasible or not, but it was the final kind of conclusion that they have come. So be aware, even with negative penicillin sensitivity test, you can have anaphylaxis because it's the most common agent to cause anaphylaxis. Yeah, so if you have any like high risk patient, past history of allergy, past history of anaphylaxis, any other food, drug allergy, so these kind of patients, you have to be very cautious when you administer a new drug, and you have to monitor that patient for then at least for the next 30 minutes, if whether to see any reactions are occurring. So patient education also a must. So patient should know if a diagnosed patient with anaphylaxis, patient should know how to identify a possible anaphylactic reaction next time. So patient education is very important and possible allergens should be avoided like food. That's it. Any questions before we? It's not finished yet. Sorry. Any questions before we move on to the case scenarios? Just briefly, I will discuss about few case scenarios. Any questions? Any questions from nursing officers? Mr. Mona Prashna Diyanada? No questions. I see you. Peripheral administration, it is you dilute your one vial of adrenaline in 100 ml of normal saline, get into a burette set, and you set the rate zero point 0.5 to 1 ml per kg per hour. So later on only you will move this patient to ICU, where you will have to, if refractory anaphylaxis, you will have to monitor the invasive blood pressures, and also you will get the CV line in. So in that context, you can of course start your normal strength adrenaline. Okay, shall we move on to the case discussions then? So, this is a 44-year-old female with known history of diabetes mellitus admitted with a wound infection in the leg to the surgical ward. There's no history of allergy. She was prescribed with IV coamoxiclair 1.2 gram TDS dose. 5 minutes after the first dose of antibiotics, she complained of faintishness. As the first responder to this patient, what are you going to do now? So what will you do? Any deteriorating patient, any critical patient, you will adhere to ABCDE approach. So you will attend to airway first. So if patient is able to talk, so there's no problem with airway. Breathing, there's respiratory rate about 30. I'm telling the figures about this for you to understand what is the clinical condition of this particular patient now who complained of faintishness following IV coamoxiclair. So she is able to talk, respiratory rate around 30, lungs are clear, saturation is 97, capillary refilling is 4 seconds. Mind you, I have stressed on this point, capillary refilling, how important during the sepsis lecture as well. This is a very sensible marker of peripheral perfusion. So capillary refilling is 4 seconds. It is as equal as lactate reliability. Pulse rate is 110. Blood pressure 70 by 40, that is hypotensive. Patient is still conscious, rational. CBS is normal. There's a urticarial rash all over the body. Temperature is normal. What are you going to do now? What are the abnormal findings here? What is the main abnormal finding that you will see here? There's hypotension, significant hypotension with compromising peripheral perfusion with a capillary filling of 4 seconds and a tachycardia. So I have told if there's possible trigger with only with hypotension, you can have anaphylaxis, but this patient have a urticarial rash as well. So what will you do? You are not alone in this world, so please call for help. So call for help. What is the definitive management you will consider? You will give IM adrenaline 0.5 ml to your anterolateral thigh. Make the patient flat, elevate the legs. You can give oxygen via non-breathing mask or high flow, and then you reassess. Meanwhile, you establish the IV access, give fluid bolus, establish your monitoring, and reassess. So this is the condition of the first dose of IM adrenaline. What you see in this? Any improvement? Is there any improvement? Yes, with regard to what? Yes, the blood pressure has improved, tachycardia has settled, capillary filling has settled, respiratory rate it was previously 30 and 97, now it's 20 with 99% oxygen saturation. So, urticarial rash also reducing, patient feels better. What will you do now? So, looks like patient has responded to the first dose of IM adrenaline. Lucky. So, what will you do? Reassurance. You can keep monitoring, continue the monitoring. If there's any suspicion of coming into the diagnosis, of course, you can send serum tryptases. Documentation. Don't forget the documentation. So, patient should be issued a red card, alert card, and patient information should be recorded. So, that's the first case. Any questions? That's the simplest one. Okay. So the same patient, so there's patient has a pineapple allergy and no other drug allergies here. So same 46-year-old female with non-diabetes, hypertension, diabetes mellitus admitted with a wound infection in the leg to surgical ward. She is allergic to pineapple. There's no drug allergy. She was prescribed coamoxiclair, and 2 minutes after the first dose, she complained of faintishness. So you are the first responder now. So this is the clinical condition of this patient. Now this patient is anxious but able to talk. So you attended the airway. Breathing wise, there's tachypnea, respiratory rate is 30, and to see there are bilateral bronchi and saturation is 95. Circulation, capillary refilling is 4 seconds. Pulse rate, there's a tachycardia, significant 130 with hypotension 75/40 blood pressure. And still she is conscious and rational with normal glycemic levels. Again, there's a urticarial rash all over the body. What will you do now? So same thing will be repeating. You call for help. So there's high suspicion of anaphylaxis. So you give adrenaline, position the patient, oxygen, IV fluid. Monitoring, you have to confirm the IV access and reassess. So, after this first dose of IM adrenaline, this is the condition. Still, patient is anxious but able to talk. Respiratory rate is the same. Bronchi is still there. Saturation, there's a slight drop from 1 point, which is 94 now. Blood pressures have not picked up. So cardiovascular stability is not achieved with first dose of IM adrenaline. D and E same. What is your management now? Yeah, second dose of IM adrenaline. Same site. So you repeat the adrenaline. Fluid boluses. Now there's a place for. Is there a place for nebulizations here? Yes. Yes, it's advised. Salbutamol nebulization, if there's with the presence of bronchi, you can nebulize. If there's upper airway problem like stridor or you suspect angioedema, you can nebulize it. Adrenaline. Adrenaline, how much? 1 in 1000, 5 ml. You can nebulize that if there's upper airway edema. And since this patient is having bronchi, you can nebulize with your salbutamol. And yeah, establish monitoring and reassess. So you reassess the patient. You have given the second dose of adrenaline. Have you given? Sleeping, no? Given, two doses given. Yeah, so what? This is the condition. Is there a improvement? Any improvement you see? No, there's no improvement. Breathing same, capillary cardiovascular stability not achieved. After two doses, you have not achieved patient any improvement. Now, what is the where are we heading to now? It is refractory anaphylaxis. So, patient have not improved. What is the next step now? You have given two doses of IM adrenaline. Now you have to give IV adrenaline infusion should be started until such time you establish that you keep giving IM adrenaline 1 milligram 1 in 1000 to the same site every 5 minutes till you establish that peripheral adrenaline. Meanwhile, you know this patient will definitely should go to a ICU because it's refractory anaphylaxis. So you arrange critical care facility. You can provide other supportive management should be done as same. So you have started the adrenaline infusion. Now there's good improvement with regard to B and C. You can clearly see lungs are clear. Saturation has improved from 94 to 97 with 15 liter oxygen. Cardiovascular stability is achieved. What will you do? You reassure the patient. You continue the monitoring in HDU setting is enough actually. Level 2 care is enough. So HDU, ICU, you can send the trip cases, documentation and patient information. So that's in the ends the second case. So this is the very last case. So you can see. Yeah, the last case. So wake up. This is the last case. You can go after this after having a tea, hopefully. So this is again 48-year-old female with a history of diabetes mellitus hypertension in the surgical ward. I don't know why this stressing on surgical ward. So there's a history of multiple food allergy, NSAID allergy, but there's no history of anaphylaxis. She was prescribed IV coamex clay 1.2 gram TDS. Immediately after first dose, she complains of faintishness. You are the first responder. Now what are you going to do? You will assess A, B, C, D, E. Patient is able to talk with regard to A. B, there's a tachypnea, respiratory rate 30, lungs are clear, saturation 97. Capillary filling 4 seconds, tachycardic, hypotensive 70 by 40, D normal, E there's a urticarial rash. What are you going to do now? Same thing. Now just concentrate on the latter part of this slide. You will see there's chlorpheniramine and hydrocortisone. Why have they added chlorpheniramine and hydrocortisone? Because this patient has multiple drug allergies in the history. Possibly this is going to be a refractory anaphylaxis, or there's very high chance of getting a biphasic reaction. So here, since you know the history very well, here you can give hydrocortisone as well, but provided you give your adrenaline at first place. Then what happens? So yeah. So so now you have given the first dose of IM adrenaline, and you have given chlorpheniramine hydrocortisone, and you given your fluid boluses, established monitoring, oxygen, everything done. So you go for reassessment. Patient is not responding now. There's no breathing, no central pulse. Now what is this? There's not responding, no pulse. Don't give me arrest without answering now. It's cardiac arrest. It's cardiac arrest. Patient has gone into cardiac arrest. Now you adhere to your cardiac arrest algorithm. You call the resusc team. You start your chest compressions 100 to 120 rate, 5 to 6 centimeter depth, middle of the lower half of the sternum, ambu ventilation, 30 chest compressions, 2 ambu ventilation. To attach your defib as soon as possible, assess the rhythm. Monitor shows asystole. What is the next step? Now this is non-shockable rhythm. Asystole and PEA is non-shockable rhythm. You give your 1 in 10,000 adrenaline 1 milligram and flush it, and continue your CPR for 2 seconds. You continue your ambu ventilation 30 to 2. Meanwhile, if you can get the LMA or intubation, do that as well. Then you asynchronize your chest compressions and breaths. You give it 10 to 12 breaths, and you continue your chest compressions. Look for reversible causes, OHS, 40s, anywhere in the world. If there's a cardiac arrest, you give IV adrenaline 1 in 10,000, 1 milligram, flush it. Look for OHS and 40s. Tell me the OHS and 40s. OHS and 40s, HS, hypoxia, yes, ETU. Hypoxia, hypertension, hypokalemia. What is the other age? Hypothermia. T's, toxins, tension pneumothorax, tamponade cardiac, thrombosis. Yes, OHS, 40s you exclude while giving your chest compressions. So then luckily this patient, in the monitor you see sinus tachycardia, and patient has achieved ROS after your IV adrenaline 1 dose, 1 cycle. So central pulse is present now. So what will you do when there's a cardiac arrest? You resuscitate the patient. Then what is the same thing that we are going to do? You reassess the patient. A, B, C, D, E. Now patient still unresponsive, breathing. There's no spontaneous breaths. You can intubate the patient. Cardiovascularly stable. D, patient again unresponsive, and E, there's a urticarial rash which is improving. Now what are you going to do? This patient should go into critical care setting. Post-resuscitation care should be adhered to. You continue the monitoring. You send the trip places, documentation, and handing over to ICU. So this is basically anaphylaxis followed by cardiac arrest. You resuscitate the patient and then successful. So that's it. Any questions? Yeah. Any questions? Nurses, nursing officers, any questions? All clear? Oh, okay. So, in the absence of questions, I would like to wind up this. So, I would like to again thank College of Anesthesiologists and Intensivists of Sri Lanka to for like arranging this lecture in order to have a quality improvement in our setup. And special thank goes to our director and deputy director, Dr. Nilanti, for with the short notice for taking all the trouble and making it a hybrid session. Dr. Nilanti, thank you very much. It was your idea at first place, making it a hybrid event so that many participants can be accommodated. So I must thank every one of you and Walawa Clinical Society, of course, and all the participants. Thank you very much. I'll wind up at this point. And you have a refreshment, I think, is it? Yeah. So you can enjoy that as well. Thank you very much.
Okay, madam.